Hello everyone and welcome to our module on glucocorticoids and NSAIDs. Glucocorticoids and NSAIDs are groups of drugs that are commonly used as anti-inflammatories and to suppress the immune system, and you will see them used in clinical practice for many conditions. I've listed some of the common conditions on this screen. NSAIDs are often used for arthritis and gout. You may have taken NSAIDs like ibuprofen yourself for headaches. They're also used for menstrual cramps, they're used to treat fever, and they're used to treat muscle aches. Steroids, on the other hand, are used for conditions like COPD and asthma. They're used in many vasculitis syndromes. You'll also see them used in lots of autoimmune diseases, in inflammatory bowel disease and transplant rejection. And this is by no means a complete list. This is just an example of some of the places where these drugs are often prescribed. It's very high yield for step one to know the mechanism of action of glucocorticoids and NSAIDs, but before we can discuss that, we need to discuss the eicosanoids. So eicosanoids are signaling molecules used by cells in the body, and they include compounds like leukotrienes and prostaglandins and also thromboxanes. And these molecules are produced by all cells in the body, and in particular, they're produced in increased amounts by inflammatory cells when there is inflammation occurring. The body produces these in response to lots of different stimuli, including epinephrine and cytokines and many other inflammatory mediators. The way the body makes these molecules is by using its own lipids in the cell membranes. When cells receive an appropriate stimulus, they will activate an enzyme called phospholipase A2. And phospholipase A2 will utilize the lipids in cell membranes to create a very important compound called arachidonic acid. From arachidonic acid, you can derive all the different eicosanoids. There are two important enzymes that modify arachidonic acid into the eicosanoids. One is called lipoxygenase and the other is called cyclooxygenase. So as we will see in this module, the way that glucocorticoids and NSAIDs work is that they inhibit the enzymes involved in this process. In particular, they inhibit one or more of the enzymes phospholipase A2 or cyclooxygenase or lipoxygenase. And as a result, you lose the function of many of these eicosanoids, including the leukotrienes and the prostaglandins and the thromboxanes. There are dozens and dozens of eicosanoids, and each molecule has multiple different effects in different organs and different tissues and on different cells. There's a very nice review article on the bottom of the screen here if you want to read about all the different eicosanoids and what they can do. For your boards, however, there are just a few that you should focus on so that you can answer the questions. The most important eicosanoid to know for your boards is prostaglandin E2. It has some very important effects related to inflammation. First of all, prostaglandin E2 can cause vasodilation. This is what gives you the redness that you see in inflammation. It also causes increased vascular permeability, which leads to the edema of inflammation. It increases the set point in the hypothalamus, which causes fever. It sensitizes nerves, and that's what causes the pain of inflammation. And then finally, it dilates the renal afferent arterioles, and as we shall see, adverse effects on the kidneys are common in drugs that block eicosanoid synthesis. So if you administer a drug that decreases the levels of prostaglandin E2, you will see improvement in all these signs of inflammation, and you will pay a price in kidney function because of the renal vasodilation effect. And we'll talk about that in a minute when we get to specific drugs. Prostaglandin E2 and prostaglandin I2 are the most important prostaglandins for protecting the GI mucosa. As we will see, NSAIDs can lead to ulcers, and that's because they decrease the level of these two important prostaglandins. Thromboxane A2 is very important for stimulating platelet adhesion, and as we shall see, when you decrease levels of thromboxane A2, you can have bleeding occur, and that's because of this effect. The major clinical relevance of the leukotrienes is in hypersensitivity reactions, and in particular, it has to do with asthma. Leukotrienes C4 and D4 are both vasodilators and bronchoconstrictors. They play an important role in asthma, and leukotriene B4 is very important for neutrophil and eosinophil chemotaxis, and this also plays a role in the inflammation of asthma. So back to our overview slide, we've talked about how stimuli cause phospholipase A2 to make arachidonic acid, and how arachidonic acid is converted into leukotrienes and prostaglandins and thromboxanes, which have those physiologic effects we just talked about. Now we're going to talk about this enzyme right here, cyclooxygenase, and how it functions to synthesize prostaglandins and thromboxanes. So it's very important you understand that there are two isoforms of cyclooxygenase. The first one is called COX-1, and cyclooxygenase 1 is constitutively expressed, meaning it's expressed all the time in many cells in the body, and its most important effect is that it protects the GI mucosa from damage. And as we shall see, when you inhibit COX-1, this can cause ulcers in the GI tract. COX-2 is inducible. It's not constitutively expressed, and it's inducible in particular in inflammatory cells, and blocking COX-2 blocks many of the mediators that are produced in the setting of inflammation. So the first class of drugs we're going to discuss are the non-steroidal anti-inflammatory drugs, or NSAIDs, and they get their name because they have anti-inflammatory effects that are similar to steroids like glucocorticoids, but they are non-steroids, hence the name NSAIDs. So the drugs that people traditionally call NSAIDs are drugs like ibuprofen and naproxen and indomethacin, and you may have taken some of these for a headache or some other inflammatory condition. Ketorolac is also called Toradol. This is often given intramuscularly in the emergency room to treat pain conditions, and diclofenac is another NSAID. There are a small number of drugs called COX-2 inhibitors that inhibit only the COX-2 enzyme. The major drug in this class is celecoxib. You may know it by its other name, which is Celebrex, and this is the main COX-2 inhibitor that people talk about. Technically, a COX-2 inhibitor is a non-steroidal anti-inflammatory drug, but most people refer to these drugs as a COX-2 inhibitor. And then finally, aspirin is also a non-steroidal anti-inflammatory drug. We mostly use aspirin these days for antiplatelet effects, and I talk about it in more detail in the cardiology module on antiplatelet drugs. But for our purposes here, just know that technically aspirin is a non-steroidal anti-inflammatory drug. So now let's talk about the traditional NSAIDs, which are all the drugs I've listed on the screen here. These drugs share in common the fact that they reversibly inhibit COX-1 and COX-2. The beneficial effects of these drugs are decreased pain, redness, and swelling, all the signs of inflammation. And that comes from decreasing levels of the prostaglandins I talked about 2 slides ago. Their adverse events all relate to decreasing the effects of other prostaglandins and thromboxanes. So by decreasing the effects of thromboxane A2, you can have decreased platelet aggregation and you can have a risk of bleeding. From blocking prostaglandin E2 production, you can have decreased renal blood flow. This can cause renal ischemia, which can present as rising BUN and creatinine in the plasma. You can see a decrease in the integrity of the GI mucosa. Remember that the GI mucosa is maintained by prostaglandins E2 and I2, and therefore people who take these drugs can experience ulcers and bleeding. And then finally, a unique side effect of the NSAIDs is that they can cause interstitial nephritis. So let's review acute interstitial nephritis. This is inflammation of the interstitium, which is the space between cells. It's not a disease of the nephron itself, and on biopsies of patients with this condition, the nephron is usually normal. It's considered a hypersensitivity or allergic reaction because it involves a cell-mediated immune response and eosinophils, although the specific type of hypersensitivity reaction, like type 1 or type 2, is not clearly understood. It's usually triggered by drugs, although sometimes it can be triggered by infections or autoimmune disease, and a classic finding is urine eosinophils to indicate that the patient has acute interstitial nephritis. So the classic presentation of this condition occurs days to weeks after exposure to a typical drug like an NSAID. There's usually fever and rash. There will be decreased urine output, which is oliguria, and increased BUN and creatinine, and all of this is due to that inflammation in the kidneys. And then there will be that classic finding of eosinophils in the urine to tell you that it's acute interstitial nephritis. The COX-2 inhibitors reversibly inhibit only the COX-2 enzyme. This gives you all the benefits of the nonsteroidal inflammatory drugs like decreased pain, redness, and swelling. However, there's less risk of GI ulcers and bleeding because recall that COX-1 is very important for maintaining the GI mucosa, and you do not inhibit COX-1 with these drugs. The downside to the COX-2 inhibitors is that they've been shown to have increased cardiovascular events like MI and stroke in clinical trials. Some of you may know the story of the drug Vioxx, which was pulled from the market after subsequent analysis of the early clinical trials showed that there were a higher risk of MI and stroke, and there were accusations that the drug company may have tried to hide from the public these adverse events. But regardless, the point is that there's an FDA black box warning that you have to be careful administering these drugs to patients who may already have a high risk of MI and stroke before taking the medication. And then finally, the COX-2 inhibitors are sulfa drugs, so anyone who's allergic to sulfa can't take them. Now we're going to move on and talk about the glucocorticoid drugs. Probably the most common one you'll see is prednisone, which is an oral drug used for many inflammatory conditions. Methylprednisolone is an IV version of prednisone. Hydrocortisone, you may know, comes in a cream, as does triamcinolone, and then dexamethasone and beclomethasone are also steroids that are used in some cases. All of these medications are steroids, and therefore they can easily diffuse across cell membranes. Once they get inside cells, they bind to the glucocorticoid receptor, and then the glucocorticoid receptor steroid complex translocates to the nucleus, and they exert their effects via altering gene expression in cells. There are many mechanisms by which glucocorticoids exert their effect on cells of the human body, but one that you should definitely know for step 1 is inactivation of NF-κB, which is a nuclear transcription factor, and it's very important in the inflammatory response. For one thing, NF-κB mediates the response of TNF-alpha. So TNF-alpha is a very important cytokine, and the way TNF-alpha exerts its effect is through this transcription factor. In addition, NF-κB controls the synthesis of lots of different inflammatory mediators, including those important enzymes we talked about a few slides ago, like COX-2 and phospholipase A2 and lipoxygenase. And just to go back to our overview slide of eicosanoid synthesis, the glucocorticoids, by their activity on nuclear factor kappa beta, can decrease the effective action of phospholipase A2, cyclooxygenase, and lipoxygenase, and this will reduce the levels of all of these inflammatory mediators here. So just like there are many mechanisms by which glucocorticoids exert their effects, there are many, many different immunosuppressive effects. One of the most important ones to know clinically is that you will see an increase in the neutrophil count. There will be an increase in the white blood cells, and this may seem counterintuitive for a drug that suppresses inflammation. However, what this drug does is it impairs neutrophil migration, so you'll see more white blood cells in the plasma, but there will be fewer of them making it to the sites of inflammation, and that's why glucocorticoids work as anti-inflammatory drugs. In addition, you can see decreasing circulating levels of eosinophils and monocytes and lymphocytes. You can also find decreased expression generally of many cytokines, including interleukins, interferon gamma, tumor necrosis factor, and GM-CSF. It's very high yield for your boards and also for clinical practice to know the side effects of chronic steroid use. Many patients take steroids every day for suppression of the immune system, and they can develop many of the effects I'm going to describe on this slide and the next one. The first effect has to do with the skin. Patients who take chronic steroids get paper-thin skin, and they bruise very easily. Patients on chronic steroids also develop a characteristic appearance called a Cushingoid appearance, named after Cushing's disease. They also develop weight gain in a very specific manner. They get obesity around their trunk, they get swelling at the back of the neck called a buffalo hump, and they get a rounded moon face. And you should Google Cushingoid appearance and get used to what this looks like. You'll see it frequently in patients on chronic steroids, and once you know what it looks like, you can recognize it immediately. Chronic steroid use leads to osteoporosis, and patients on chronic steroids frequently have hip fractures. Their sugar levels can get high. They can get hyperglycemia from increased liver gluconeogenesis and also decreased glucose uptake in the fatty tissues. Chronic steroid use is a well-described risk factor for cataracts in the eyes. Many patients on steroids develop a myopathy. They complain of muscle weakness, and this is because there is skeletal muscle catabolism going on. Amino acids are being generated for gluconeogenesis in the liver. Patients on steroids often get gastritis or peptic ulcers. They've been shown to have gastric hypoplasia from the steroids. They have more acid secretion, and they have less mucus synthesis. A feared complication of long-term steroid use is avascular necrosis. This is also called osteonecrosis, and this is collapse of bones. It most commonly occurs at the femoral head. This is an x-ray here of someone with avascular necrosis of the femoral head. The bone should be nice and rounded all the way around, but it's jagged and collapsed right here from avascular necrosis. The exact mechanism is incompletely understood, but it involves interruption of blood flow. Many people describe it as an infarct of the bone. There's demineralization and bone thinning, and ultimately there is collapse. This condition is commonly associated with long-term steroid use. Some other important risk factors include lupus. So people with lupus have a big problem because they need steroids for treatment of their lupus, and both the steroids and the lupus are a risk factor for this condition, and they commonly develop avascular necrosis after being on steroids for many years. Also sickle cell anemia and alcoholism, and finally trauma. And the way this will usually present, particularly in a board question, is someone who has been on steroids for a number of years and now presents with pain in their hip. If patients are taking steroids every day and they abruptly discontinue the medication, they can develop a life-threatening adrenal crisis from adrenal gland insufficiency. The reason is because long-term steroid use suppresses the hypothalamus-pituitary-adrenal axis. Essentially, patients stop synthesizing their own cortisol because you're giving them cortisol every day in the form of a medication. If you abruptly discontinue the medication, the patient cannot increase their adrenal gland synthesis of cortisol fast enough, and they develop acute adrenal insufficiency. The symptoms of adrenal crisis include hypotension and shock. This is the dominant feature of the way the patient will present. In addition, they'll have a poor appetite. They may have nausea, vomiting, and abdominal pain. They can be very weak and fatigued and lethargic. Sometimes there is a fever, and there can also be confusion or coma. and this can be a life-threatening complication of abrupt discontinuation of steroid therapy. And that concludes our module on glucocorticoids and NSAIDs.